Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1945, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers and are not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it should not be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice. My name is Dr. Clark Madsen. I'm on the board of the Ogden Surgical Medical Society, and I work out of Ogden, Utah in family medicine and sports medicine. And so I'll be your host again here today, and I'm here with Heather Hylison.
Hi, I'm Dr. Heather Hylison. I'm an emergency physician at the Katy Hospital with Utah Emergency Physicians. I'd like to introduce Dr. Stenehjem, who is an infectious disease specialist. He is the director of Antimicrobial Stewardship, and he oversees the Antimicrobial Stewardship programs across 23 hospitals and over 200 outpatient clinics throughout Utah, Idaho, and Nevada. He trained in internal medicine at the University of Colorado and completed his infectious disease fellowship at Emory University in Atlanta.
And we are super happy to have you here today. We've had a lot of really distinguished guests on this podcast, but I don't know if we've had anyone who has more insight into current conditions than Dr. Stenehjem. So really appreciate having you here today. Welcome.
Thanks, and pleasure to be here.
We kind of got a lot of things to cover today we wanted to talk with you about, but I think it would be wrong if we didn't mention the amount of stress that you've been under in the past year. Just before starting this podcast, we were talking about all of the crazy things that have happened in the past year, including you just had a young child born about this time a year ago. Can you tell us more about that?
Yeah, that's right. My son was born on the 21st of March, and that was quite a week leading up to that. This is the 1-year anniversary of really WHO declaring COVID a pandemic. It was the week of Rudy Gobert testing positive, our school shutting down, and really the beginning of, the pandemic here in Utah. And it was that Sunday that then my son was born and all the chaos that surrounded that. And it was quite a week to remember.
It's been a whirlwind of a year for multiple reasons, I imagine. Newborns, COVID pandemic, working as an infectious disease expert.
Yeah, it really has been a unique year. Some really good, some really bad. It's been challenging. It's a new virus. It's a new disease that we all had to deal with. And, the people at large had never dealt with a pandemic like this. And so everything was new. We felt that within Intermountain Healthcare and as an individual, as an ID doc.
Well, we have had some discussions about COVID on this podcast in the past, but I think it would be helpful to get your unique experiences with the virus. Is there anything about this pandemic that's kind of surprised you, whether that's, how it spread or how the community has responded to it? What's kind of been the most revealing thing for you in the past year?
There's a couple really big poignant things that comes to mind. First is just how the medical community responded. And, I couldn't be more proud of the state of Utah and the medical groups that we have here, our hospital systems and how they work together. Whether it be Intermountain, University of Utah, HCA, this was, one of the only times where you saw those groups come together with a common mission and a common goal. And you had load leveling where if they say, hey, we couldn't take this patient at Intermountain Medical Center, but we're going to send them to your hospital. That was just really incredible to see, and to see how nimble our systems could be when forced to, right? So setting up testing centers all across the state of Utah, that was done in a matter of days. And you think about how initiatives roll out and how slow they can be and painful and those types of things. But, look what we can do when we all set our mind to something and are focused on it. And it can happen overnight. It's just dramatic how that is impressive. Not to mention the healthcare community at large and the fact that, when this pandemic hit in January and February, if somebody were to ask me like, hey, do you think we'd have a vaccine for this a year from now? I would have laughed in their face. Like, absolutely not. But to go from identifying the sequence of the virus in January to getting a vaccine in a novel technology with an RNA platform, in less than 12 months. I mean, it's just incredible, like how focused and how impressive those efforts were. And I thought that was just remarkable. And then, on the other side, kind of what's the thing that surprised me in the bad way was how divisive this topic became, how politicized it became, and how it was really hard to get good, consistent information. And it was hard for the public to know who to listen to. And it was really challenging to really kind of fight, not only the virus, but also public perception and the politics behind it. And I would have never expected that when this started, but I did a lot of advocacy work over the course of the year. And it was the first time that as a physician, I got personally attacked about my views based in science. And, that was really surprising to me and unfortunate.
Sorry that you had to go through that. I think a lot of our listeners could probably relate to that. This was kind of a year where we showed our best as a medical community, but then we also showed how we can shoot ourselves in the foot. Hopefully we all remember some of the lessons from this year moving forward.
Hope so.
We would love to talk about COVID this whole time, but I think there's some other things that have even broader scope to them. And we kind of wanted to focus a lot of our attention on your role in or crusade, or however you would like to describe it, to maintain our antibiotic stewardship. Would you be able to just kind of briefly tell us your role in that, and we'll kind of go from there?
I'm the medical director of antibiotic stewardship for Intermountain Healthcare. I oversee antibiotic stewardship, or getting physicians to better prescribe antibiotics more appropriately over inpatient settings, outpatient settings, and transitions in care. And so really have the lens of how does us as a health system prescribe antibiotics across all the different care continuum? And then how do we influence that to improve prescribing, all in the face of, trying to improve patient safety, reduce drug resistance, to really improve care for our patients. And so that takes us all the way, looking at McKD inpatient ICU antibiotic prescribing for pneumonia, to, outpatient management of urinary tract infections, to the management of antibiotics in home care, all of those things, telehealth, all of that fits under kind of the umbrella of my office and in Intermountain Healthcare.
So thinking about antibiotics stewardship in the outpatient setting or the ambulatory setting, there's got to be something that we can do as prescribers that would have the highest effect with the smallest change. So is there something that we could do that gives the highest yield for stewardship?
Yeah, when we look at outpatient ambulatory prescribing, the majority of antibiotic prescribing comes in, 3 buckets. That's respiratory infections, urinary tract infections, and skin infections. And so just identifying that right there. So if you as a clinician says, where am I going to focus on antibiotic prescribing? It's one of those 3 conditions. Easy. And when you look at the urgent care in the ED, likely is that respiratory prescribing. So whether you call it pneumonia or bronchitis or sinusitis, just respiratory antibiotic prescribing is by far and away the biggest bucket of encounters that you could focus on from an antibiotic prescribing standpoint. And so, when we've done our initiatives within Intermountain, we've focused primarily on respiratory prescribing because that drives the majority of antibiotics. And within that, there are plenty of diagnoses and syndromes that don't require antibiotics at all, but still get them. And so, the biggest bang for your buck from an antibiotic stewardship standpoint is to prevent a prescription versus shortening the duration of the antibiotic prescribed. And so we've targeted mostly those and focused on conditions like sinusitis, otitis media, bronchitis, as to be really an opportunity for us to engage with our patients and talk about, is an antibiotic really needed here? Let's not prescribe one, see how you do, and give kind of contingency plans. And so biggest bang for your buck, I would say, look at respiratory prescribing. Other areas to look at: UTI management, skin and soft tissue infection management.
Well, I was with a patient last week where this came up. Gentleman came into our same day clinic. I was looking at his ears. He came in bilateral ear pain, classic presentation for otitis media on both of his ears. And he said, I need you to prescribe me a Z-Pak. And I said, well, why do you want a Z-Pak? And he said, well, the last time I got this, I had a Z-Pak, it went away. And I asked him, well, when was that? And he's like, oh, it was about 10 years ago. And I had to try to explain him that, a lot has changed in the resistance patterns of bugs in the past decade. At that moment, he immediately stood up and just walked out of my room without saying another word to me. So I don't know if you see that very often too. It's really a challenge, I think, on educating the physicians and the other medical staff, but also our patients on this.
There's a lot to unpack there, and you're absolutely right. We are, in many instances, trying to undo a culture of antibiotic prescribing that was set 15 to 20 years ago. And there are people that are just rooted in that. If I have a cold, I need a Z-Pak. There's people that you cannot convince otherwise. In a lot of our work, we've engaged patients, and we've gone and we've interviewed patients to understand what they are coming to a clinician for. Urgent care is a great example. So when we talk to the clinicians, when we talk to the physicians and APPs, and we ask them, why are patients coming to the urgent care with respiratory symptoms? What are they coming for? Invariably, the clinician said they're coming for an antibiotic. Like, that's why they're here. So I need to address why they're here and engage with them on that. When you ask the patients, why are you coming to the urgent care for this? They say, well, I want to get an opinion from somebody who I really trust and I value. I want somebody to look at me and give me their expert opinion. And it's this big discrepancy of what patients are looking for and what we perceive them as wanting. And so once we kind of made that realization and then was able to feed that back to clinicians to say, have that discussions with the patient of, what are you coming here for? Like, what is it that you perceive as value? And most of them will say, I just want you to check me out and let me know if I need anything. And if I don't need an antibiotic, that's great. But what can I do to make me feel better? And learning that most of the patients, there's going to be your one-offs, right? Like your patient directly told you, I want a Z-Pak. But those are getting to be fewer, and more patients are understanding some of the complications of antibiotics. And I think that culture is changing, and it makes it so you can have a discussion about this and be able to offer symptomatic therapies that, improve symptoms, but then also give them that kind of contingency plan. Well, if you're not better in X amount of days, or if you're having fever in 3 days, these are the things I want you to do. Either call, come back, fill a delayed prescription, have something there to be able to offer the patient as kind of a contingency plan.
I was looking over the Antimicrobial Stewardship website, and I found a few resources, handouts to give to patients that discuss some alternative treatments, which I found to be really helpful. I'm going to start using in my practice. What kind of tools are out there to help physicians kind of help direct the conversation to other non-antibiotic options?
So for years, CDC and others have been focusing on this viral prescription pad. It's just a generic piece of paper that says, here are some options to, relieve your symptoms. And when we talk to patients about that, they're like, well, that's great, but that's not directed to me. Right. And so what we created, and is accessible online, without a firewall or anything, is a personalized over-the-counter prescription. And so it's really meant for the physician or APP to fill out with the patient. And what it is, it's separated by symptoms. There's a box for fever, sore throat, congestion, ear pain, et cetera. And there's about 4 or 5 different options in each one of those boxes. And you as a physician can say, for your symptoms, for your fever, for your ear pain, for your sore throat, I would recommend this, this, and this. And you check those boxes. And then they can take that to the pharmacy. And we spent a lot of time actually just going through the aisles of our local pharmacies, whether it be Smith, Harmon's, and looking at what's there and making sure that the things that we had on that list is what we have in our pharmacy. And so then they can take that piece of paper and say, okay, my doctor told me to take naproxen. Let me find naproxen and go get that. And so it really personalized that kind of over-the-counter prescription for them. And when we asked them why that was so important, They said, well, I was heard. That physician, that APP heard my symptoms and developed an algorithm for me. And that was something that they valued. And so it really was, regardless if you give an antibiotic or not, we should still be doing that because our mission is to make them feel better. We should be doing that regardless if I get amoxicillin or a Z-Pak or whatever. We still should be doing that. So that's one thing. And the other is that we've really focused on a delayed prescription, especially in the emergency department and in the urgent care, where they don't have the ability to call back, right? It's not like they're going to their primary care docs. They can just call back, say, hey, I'm still not feeling better. Can you call something in? But in ED and urgent care, we focus on this delayed prescription. And so the majority of sinusitis doesn't need an antibiotic, but sometimes it does. And so the way these things work is that they come in, they say, okay, here's a symptomatic therapy kind of prescription, go do this. But if your symptoms aren't better in 5 days, and these are the things I want you to look for, here's a prescription that you can fill if needed. And when we look at those prescriptions, of the people that got those delayed scripts, less than 50% filled them versus somebody who got a regular script, 90% filled them. And so it's another opportunity for us to kind of meet that patient where they are. And you can understand, I mean, some of these people are having to take a day off work or a half day off work. They don't want to come back to the ED or urgent care. Maybe they don't have a primary care doc. And so being able to give them that where they can fill it and not have to, take a day off or do all those things is valuable to the patient. So those are two of our strategies that we worked on, was really focusing on those symptomatic therapies and then also a delayed prescription when it was appropriate. Sinusitis, otitis media are biggest, areas that we focused on.
One thing I can take away from what you're saying there is, in the past, when I've thought about antimicrobial stewardship, a lot of it is just being told not to prescribe antibiotics when it's not indicated, but it's more of what can we do to add value to the patient's experience besides the antibiotic.
You're absolutely right. Primary care docs go through so much and they have such a hard job. We can't just be saying, don't do it, don't do it, don't do it. We need to be able to provide them tools to make it easier to manage the patient and manage the patient's expectations. That's not something that we really like to focus on. We really want to, provide tools to clinicians to make their jobs easier and make those discussions with patients easier.
And I think we can look to see if we can add a link to some of those tools with the podcast, so you can use them in your own practice. Like you said, it's not hidden for any specific group. This is available to any provider that wants to use it.
That's right. Yep. I think that's a great idea.
Are there any key phrases or like a script that you could help us with? Because I feel like in the emergency department, when I'm talking to a patient about alternatives and symptomatic treatment, I can just see on their mind, like, when are we getting to the part where you're writing the antibiotic? And so I found that one of the ways that we can change physician behavior is to kind of give them a script in a way of, this is kind of the way to approach it. Do you have any ideas about that?
There is a body of literature about communication training on how to effectively communicate with patients that are seeking care for whatever condition. It's not something that we've done a lot with. The reason being is communication training is hard. You're trying to reach hundreds of physicians and APPs to help them kind of talk through what that would look like. There is now a growing body of literature that is focusing on that and what's the most effective communication strategies for talking to a patient that wants an antibiotic. And so we haven't done much with that. We are certainly looking for it. And some of the areas that we look at are these kind of open-ended questions to really understand why the patient's seeking care, but then also talking through, what are the potential downsides of antibiotic therapy and making that real. And, talking to somebody about multi-drug resistant organisms, that doesn't help. They say, well, it's not going to affect me. And probably not, probably won't affect them, right? But, talking to them about allergic reactions, talking to them about the diarrhea that they're going to have, talking to them about the fact that I'm more likely to give you a side effect from this antibiotic than I am to help you cure your viral infection. That's the case with sinusitis, right? Sinusitis, the number needed to harm is actually less than the number needed to treat to benefit. And so kind of putting it into those real world terms about not necessarily the conceptual population level multi-drug resistant organisms, because that it's not real to them, but talking to them the fact that it's very real that I could potentially give you pretty bad diarrhea that's not necessarily C. diff, but just antibiotic-associated diarrhea, that's going to come at no benefit to your sinusitis. And so, trying to personalize it to the patient and taking it away from this conceptual MDRO discussion that we've been focused on for years, that just hasn't worked with patients.
I like that. There's nothing like a conversation stopper, like talking about diarrhea.
Yeah, right.
So this might be a good opportunity for us just to take a minute and talk about something a little bit more lighthearted. You mentioned that you recently went on a trip, or can I call it vacation when it's to Arkansas?
I think, yes. My last vacation was to Bentonville, Arkansas, just about 4 weeks ago now. So my extended family lives in Minnesota. Bentonville, Arkansas is 12 hours directly south from my brother and his family. And it happens to be the home of Walmart. Walmart has put in millions of dollars into the town of Bentonville and made it this mecca for mountain biking. And it has been just in the past, 8 years or so. And so there's now 500 miles of trails in Bentonville, and it's this lovely, cute little town with all sorts of good restaurants and breweries, et cetera. And so he said, this is great. And you can bike year round. I'm a mountain biker, my brother's too. And so we're like, this is great. We'll meet there and we'll have, it'll be a little chilly, but it won't be too bad. We happened to time it with that polar vortex that hit all over the South. And so we came into Bentonville, and then it immediately snowed 8 inches, and it was the coldest it's ever been in Bentonville.
Oh no.
For over 100 years. And so we were hunkered down in this vacation rental that we had rented with my brother's family and my family. And we weathered the storm over the course of the week. We never got to bike. We never got to go out to any restaurants, but we had good family time, and it was just incredibly poor timing on our part to take a vacation to Bentonville, Arkansas, in a polar vortex.
You're telling us you left Utah in the winter to go mountain biking in Arkansas and got trapped in a snowstorm. That is the worst luck.
That's a very good description. And it was colder in Bentonville than it was in Utah or in Minnesota, where my brother's family came, and they were coming to get a little warm. So it was an ill-fated trip, but we had a good time with family regardless.
Well, I was going to ask you which had better mountain biking, Utah or Arkansas, but I guess it'd be hard for you to answer that.
Utah, clearly.
Yeah, clearly.
So you're going to have to sell your family a little bit more on, hey, kids, let's go to Arkansas next time, maybe.
We did come away with an appreciation for Northwest Arkansas. It was beautiful, just not when it's covered in snow.
Well, we've got just a couple of minutes left, and there was an area that we were really interested to talk to you about. Apart from the work with the antimicrobial stewardship, or actually kind of in conjunction with that, there's a lot of work going on with telehealth, and kind of tell us the role of infectious disease in telehealth and how best to utilize it.
When we think about telehealth, we can think about telehealth in the inpatient setting and in the outpatient setting. In the inpatient setting, Intermountain Healthcare is a great example. We have about 17 small hospitals across the state of Utah, ranging from critical access hospitals to these kind of mid-size hospitals like Logan Regional, Riverton, Altaview, et cetera. And in 2013, those facilities did not have access to any infectious disease expert and didn't have access to any kind of antibiotic stewardship. They were just kind of out there on their own. And if they needed kind of subspecialty care, they had to either phone a friend that they knew, try to get in touch with somebody at Intermountain Medical Center or the university. It was just a really challenging situation for them. So we set out to look at, do we need stewardship? Do we need infectious disease in these small hospitals? Nobody's looked at that. We don't know. And it turned out once you start measuring antibiotic use, that small community hospitals with beds less than 200, use antibiotics at the same rate as large hospitals. 70% of US hospitals have less than 200 beds. So the majority of our hospitals across the US are small hospitals that don't have access to infectious disease. They don't have access to antibiotic stewardship. And so we thought that was an issue. We did a randomized control study of how to do stewardship in small hospitals. Do you have to do a lot of it? Do you have to do a little of it? Turned out the more you did, the more impact you had. And part of that project was starting a hotline for infectious disease consultation. And I was pretty junior when I started this, and this was kind of just like, oh, you know what? We'll have this hotline. And if somebody has an ID question, they can call. And I, was maybe naive. I didn't think they were going to call. I thought, they'd been doing this for decades without an infectious disease doc, that nobody's going to want to talk to us. So we started this hotline, and immediately the phone started ringing. And over the course of a year, I fielded 1,500 phone calls from just our 15 small community hospitals that were part of the study. And the questions that these docs were asking were so good, so complex, that it just made me wonder, like, what were you doing without an ID doc for decades? Like, how did you manage? It just gave me such respect for these clinicians that just did it all. So it was with that knowledge of, like, yes, they need help from an ID standpoint. They could utilize this. And the fact that their antibiotic use was just as high as ours, that we said we need to do something about it. We developed the first infectious disease telehealth and antibiotic stewardship program. And that is now set at Intermountain Medical Center, and it's staffed by one of 3 ID docs. We have 2 ID pharmacists, and we provide full ID consultation through cameras or through e-consults or just through a phone conversation with clinicians. And we also essentially mentor them and their staff in their stewardship program. And so we are offering us as a resource. We help them with data. We help them with interventions, but we do it in conjunction with ID consultation. And that model now has been in place since 2016, and it's become really a kind of a national standard of how you can do stewardship in small hospitals in a network-based setting. And it really was kind of utilizing the strength of a healthcare network to be able to offer this to our small facilities. And now, our partners in Logan, Riverton, Altaview, all these small hospitals, we're just a phone call away, 24 hours a day, 7 days a week. And we can turn cameras on, look at rashes, look at cellulitis, make recommendations, treat patients, place orders. And it's really worked well to really improve the care. And the patients don't necessarily need to be transferred to our larger facilities. And not to mention, when you talk to the actual clinicians, it's just so much easier for them. It makes their lives so much easier in terms of trying to access somebody, even just to ask a question like, hey, I got this in the urine. What do I do with it? Those are questions that we can answer easily. And, we're set up now to be responsible for those questions, and we're happy to do it. In the outpatient setting, that's a whole new world that we're exploring because of COVID. There's a huge transition, as you probably know, of outpatient ambulatory care moving to the tele world. And how do we monitor? How do we assess? How do we evaluate antibiotic prescribing and tele visits is a whole kind of another discussion, which we're actively involved in.
Yeah, I imagine in a few years from now, we'll have another discussion on how telehealth has evolved in the next couple of years. It's already changed so much for us in the last year. I imagine it's going to continue to develop.
Yeah, it's not going away. I mean, I think it's definitely shown its value, and patients love it. And I think it's at a point where we just are going to get better at it, and it's going to get more nuanced. And I think it's here to stay for sure.
So can physicians in the community access that telehealth program that you're mentioning?
Mm-hmm. So it's set up for our, Intermountain healthcare clinics and also hospitals. And so any of our clinics, whether it be family medicine, urgent care, EDs, all can access the hotline, 801-50-SCORE, SCORE. That's there for us to be able to answer their questions and be able to review the chart too. So that's one of the huge benefits of this system, is that if somebody has a question, they can call us, we can get their FIN, we can review the chart with them, we can review the cultures in real time. We can even drop a note to give our recommendations. And it really helps that communication. I mean, how many times I've gotten called with, I've got Enterococcus in the urine, but it's actually Enterobacter, gram positive versus gram negative. And it's just a communication breakdown. And so we are now able to obviously review the chart, make recommendations, and those types of things. And it's really pretty slick. And we have lots of clinicians in the ambulatory setting use it. And it's a great way to, get referrals into if you need it.
It's great. Well, unfortunately, I think this is a good spot for us to wrap it up for today. We really appreciate you for coming on. So I want to thank Eddie for coming on and kind of giving us an update on stewardship. And hopefully the next time we talk, there'll be less COVID to talk about and more making our system a little better like we finished off with. I want to thank Heather for joining me again.
Thank you.
Any parting comments you'd like to give us? Any last thoughts?
thank you for having me on and having a venue to talk stewardship. I think it's, an area that we're going to be talking more and more about as we see drug resistance continue to evolve. And it's certainly going to be an important topic for us moving forward. So thanks again.
All right. Well, thank you for listening to the Ogden Surgical Medical Society podcast. And hopefully you can take what you've learned here, make your practice a little bit better, and so we can continue to provide the best care in the world here in our own backyard. And we'll look forward to bringing you another podcast real soon.
Producers for this podcast are Clark Madsen, MD, MS, Teresa Poskedra, MPC, and the Ogden Surgical Medical Society Board of Directors. The Executive Director is Teresa Poskedra, MPC. Your hosts for this episode are Clark Madsen, MD, MS, and Heather Hyluson, MD. Editing and sound design is by Colton Gomez, and this is all supported by members of the Ogden Surgical Medical Society.